6 p.m. in Paris, 9 a.m. in Seattle. It's noon in Jacksonville, Florida. This is the International Academy for Clinical Hematology Journal Club. A very warm welcome to all of you guys joining us for this monthly journal club brought to you by the IACH. And for today's session journal club, the Scientific Steering Committee has chosen this paper recently published in Blood. Actually, it was published on the 26th of December, so that was like a sort of a Christmas gift. And this is the final comparative analysis of the so-called Alpine trial showing sustained benefit of zanubrutinib versus ibrutinib in patient with relapse refractory CLL. Here you can see the abstract summary of this relatively long-term follow-up of this trial, and we'll discuss, of course, the value of this trial and the importance of having long-term follow-ups. Superiority of zanubrutinib over ibrutinib was established in this Alpine randomized trial, and here we have an extended follow-up. And to make a long story short, it is clear that fewer zanubrutinib patients have died than ibrutinib patient, highlighting likely a better efficacy, but of course there was already a progression-free survival benefit. And in terms of safety, actually there were no cardiac deaths reported with zanubrutinib versus 6 deaths with ibrutinib. And in general, most of the cardiac events were lower with zanubrutinib. So we have here a trial with roughly 3.5 years of a median follow-up, demonstrating that zanubrutinib is more effective and safer than ibrutinib with an excellent safety profile. So this is the design of the original trial, a very nice phase 3 randomized trial. At the end of the day, 327 patients received the standard of care control arm ibrutinib, and 327 patients were in the so-called experimental arm with zanubrutinib. And the red curves are about the zanubrutinib group. The blue curves are about the ibrutinib group. And I think it is quite straightforward, highlighting that the zanubrutinib curves are always doing better than the ibrutinib curves. And this is also about the cumulative incidence of cardiac or cardiovascular AEs of interest. And again, without going into all of these details, and we'll dig a bit deeper with our guest, there is a clear higher incidence with ibrutinib compared to zanubrutinib. So my personal take-home message from this trial is about the superiority of zanubrutinib compared to ibrutinib in terms of efficacy and safety in the relapse refractory CLL. And we may wish to discuss whether this is going to be relevant for future practice, because obviously now we're moving into using BTK inhibitors frontline. And interestingly, and I believe this is good news, the study was closed actually early to enroll in long-term extension study. And it looks like, at least based on the study, zanubrutinib is preferred over ibrutinib. And in order to discuss this, I think, important paper, we're very fortunate, privileged, and honored having the senior author of the paper with us, namely Dr. Mazyar Shadman, whose expertise in CLL and lymphoma is very well known. So Mazyar, thank you for joining us. It's an early morning working day for you in Seattle. Thank you for your support to the IACH. And the other panelist, who is also another CLL expert, a very active member of the ICH team in charge of the lymphoma and CLL track. You may remember this, namely Dr. Kharfan Dabaja from the Mayo Clinic in Jacksonville. Mohamed, very warm welcome. So thank you both for joining. And of course, the audience can join us and send their questions, their comment. I'll be more than happy to share them with the audience. So first question is usually, it's just sort of an SOP in the journal club. It's to you, Mohamed, the non-co-author. Just give our audience your general feeling when you saw this paper, when you read it first time during your Christmas holidays. Was it a wow effect? What was your feeling about these results? And also, I would kindly, because I think we need to set the stage for the discussion, kindly ask you to give us a sort of an overview about the treatment algorithm of CLL these days.
Sure. Thank you, Dr. Mohty, for the invitation. It's always a pleasure to be with you and certainly with this important forum, IACH. So as you remember, this original study was published back in 2023, the early part of 2023, and that was the initial report of the Alpine trial, which at the time had a little over 2 years of median follow-up. So this one is really a longer follow-up at 42.5 months. So certainly adding another 13 months or so of follow-up for this. This study kind of follows another comparison with a different product, which was designed to be a non-inferiority study, and that was ibrutinib versus acalabrutinib. This study actually intended to demonstrate if there was a superiority of zanubrutinib compared to ibrutinib. So just to give a little bit of the background there, the primary endpoint of this study was overall response rate, and there were over 650 patients, a one-to-one randomization. To refresh the mind of those who may not recall that New England paper, the median age was around 67 for either arm, so very well balanced. Over 80% of the patients have been treated with a monoclonal antibody, CD20 monoclonal antibody, and over 70% of patients have received chemoimmunotherapy, whether that being FCR or BR or so on. So some other therapies were also included that included a very small percentage of patients getting immunomodulator therapies and so on and so forth. So I think that another importance of this study is that it was conducted during the time where COVID was very active. So that's why you will see COVID as being one of the most undesirable side effects that this patient developed. So Zanu prescribed at the standard 160 twice a day and ibrutinib around 420 milligram daily. The study did not allow crossover to my knowledge. And what it does is it shows that there was a sustained benefit in progression-free survival with a hazard ratio of around 0.68, reflecting a 32% reduction in the risk of progression or death, as you mentioned in your introduction. Interestingly, in my opinion, and that curve that you show there, those three survival or progression-free survival curves, you can see that the benefit was not only seen in all comers, but when they look specifically at the patient who have more higher risk disease, such as 17p deletion or TP3 mutation, you can see that there was a significant difference favoring zanubrutinib in that particular comparison. And so that's important to keep in mind. One important aspect of this is that the authors do report, and I'm going to certainly defer to Dr. Shadman, that there was a deepening of the responses over time. And I think the reported on this study was around 85.6% for zanubrutinib compared to 75% for ibrutinib. Also, not surprisingly, this is a second generation BTK compared to ibrutinib, which is the initial generation of BTK inhibitors. It is thought to have a much more specific binding, so there is more occupancy of the BTK, and there is certainly more specificity, which means that perhaps there is less of an off-target effect. That is probably what is blamed as the cause of cardiac toxicity. So having a less off-target effect is what we believe the reason why it translates into less cardiac toxicity. In this case, as you mentioned, 7% rates of AFib versus around 17% for ibrutinib, and no cardiac deaths for zanubrutinib compared to around 6, I believe, patients who died from cardiac events in the ibrutinib arm. So overall survival was not reached in this study. And I would say that the toxicity profile for one of the most frequent non-hematologic toxicity was COVID infection in almost 40+% of patients treated with zanubrutinib, and around 30-something% for patients who were treated with ibrutinib. Diarrhea was, I would say, comparable, and but the main difference was in patients who have lower risk of AFib, aflutter, which, as I mentioned, was 7 compared to 17%. So I would say that also there was a little bit of a less discontinuation of the zanubrutinib compared to ibrutinib, 21 versus 28%, and discontinuation due to progression was also lower at 18 versus 22.5% or so. So certainly important data. You asked me about the algorithm of chronic lymphocytic leukemia, and I would say that it is very important to emphasize that probably there is not a one approach fits all patient, and I think you have to sit with your patient, discuss the goals of treatment, and certainly I think that monotherapy with BTK inhibitors is an acceptable treatment option if a patient is deemed to be more frail, less fit, and having more comorbidities. I think the younger, more fit patient, you may discuss the time-limited therapies, whether doublet or triplet, and that's certainly a good discussion. And most of those will probably combine a BCL2 inhibitor with a BTK inhibitor. Some of them are going to the extent of adding a third component, which is typically a monoclonal antibody. So I think that's kind of in my mind the algorithm based on patient fitness and treatment goals. So fit versus unfit and so on and so forth. And I think where it is getting more complicated is really the treatment of relapsed refractory disease. Now, probably several years down the road, this data may be a little bit obsolete since it will be probably rare to see patients who will be treated with chemoimmunotherapy as frontline. So I think that the Alpine study will become probably less of relevant over time as these agents are being used more in the frontline treatment. So that's kind of the glimpse to the future, and that, in my opinion, is where the treatment algorithm is. In the relapsed refractory setting, we have certainly CAR T-cell therapy playing an important role. We have non-covalent BTK inhibitors also playing an important role there. BCL2 inhibitors also are integral components of this. And there is a not approved yet, but with promising data, is certainly data on bispecifics presented at IACH with epcoritamab. And also there is also certainly data with BTK degraders, very impressive data with 2 compounds that certainly show that these agents are going to be active also in the relapsed refractory disease. So that's kind of my overview for this Alpine study. I think the important message here is that the responses are sustained. Some of them deepened over time, and certainly the toxicity profile, particularly with the cardiac, is favorable for zanubrutinib compared to ibrutinib.
Thank you, Mohamed. Very clear overview. So Mazyar, now up to you. Can you tell our audience why performing this relatively long-term follow-up is important in this setting? But also, I think just to echo what Dr. Kharfan Dabaja mentioned, if you can walk us through, because I think people are now confused with the different BTK inhibitors, covalent, non-covalent, but also BTK degraders. So if you just give us an overview of all this.
Of course. First of all, thank you for having me. It's a pleasure to join this great panel to discuss Alpine and current and future CLL treatment landscape. So just a quick background on why Alpine and why longer follow-up. As Dr. Harfan Dabaja mentioned, this study, Alpine, is a one-to-one randomized of Zanu versus ibrutinib in the relapsed CLL setting with a primary endpoint of non-inferiority and superiority of overall response. So that endpoint was actually published a couple of years ago, more than that, a couple of years ago, 3 years ago. And the study met the primary endpoint. At that time, the follow-up was not mature enough to report of any PFS. And then in 23, in 22, actually, ASH 22, this follow-up was presented at ASH and followed by a New England Journal of Medicine publication with 29 months of follow-up showing that zanubrutinib, now we're looking at PFS as a main secondary endpoint, and showed that zanubrutinib was superior to ibrutinib in terms of efficacy in the entire population. And also in a pre-planned analysis, we looked at high-risk population of del17pp53 mutation. And even in that high-risk subpopulation, we saw that zanubrutinib was superior from the efficacy standpoint. Now, one of the questions that came up after that presentation and publication was naturally comparing this to Elevate-RR, which, as was mentioned, was a similar study of acalabrutinib versus ibrutinib. We all know that comparing cross-trial is not something that we should be doing, but I'm just giving you the kind of the perspective of the importance of reporting this long-term follow-up. Now, the Elevate-RR efficacy has only been published once, and from my knowledge, I don't know if we will have more efficacy follow-up. And the median follow-up was around that same follow-up that we recently published, around 40 plus months. So we believe that and when you look at the Elevate-RR PFS curves, at some point those curves kind of cross. So the question was, how do you know that the PFS curves of Alpine will not cross with the same follow-up? So once we got to that 42.5 month follow-up, which is the published paper, a little bit actually longer than the ASH presentation in 23, we thought that it would be important to share that with the community. But with the same follow-up now, similar to Elevate-RR, we're continuing to see the same efficacy advantage of Zanu over ibrutinib in the entire group and also in this high-risk subpopulation. The other question that came up with the New England publication was, you have a drug that's better tolerated. Do you think that improves efficacies because just people stop taking ibrutinib? And of course, if you don't take the drug, it doesn't work. So even with that follow-up, 29-month follow-up, we looked back and we provide responses that we don't think is the case, but with the longer follow-up, which we just published, we thought that it would be important to address those questions. So we did a number of sensitivity analysis to kind of address those questions. Number one, we only looked at patients who progressed while taking drugs. So kind of eliminating the chance of this being due to not taking the control arm. We also did another analysis, kind of censoring for patients who switched to another subsequent therapy. As we know, when you have PFS as the primary endpoint, technically patients actually remain on analysis, even if you switch treatment to something else, because you're not having an event, which is death or progression. So if you switch from, let's say, ibrutinib to drug C, that patient remains on the care. So we did a sensitivity analysis kind of censoring those patients. And then the last thing we did was also censoring COVID-19 deaths. And regardless of the type of sensitivity analysis, we continue to see the same effect of hazard ratio being significant. So I think, and it kind of goes back to the hypothesis that this was a pretty bold hypothesis for the study going for superiority over ibrutinib, right? And, the idea was that you do see with zanubrutinib the drug levels being above IC50, regardless of the dosing of once a day or twice a day, you have a very high BTK occupancy with BID or once a day dosing. So there was a hypothesis behind seeing this efficacy, and I think the study showed that. And for the safety profile, of course, long-term follow-up, we all know it's critical. And as you mentioned, we still not seeing any cardiac deaths due to on the zanubrutinib arm, which is very heartwarming to see that. I mean, we'll all worry about small number of patients who we see or read about in terms of having major cardiac outcomes. The cumulative incidence of AFib, aflutter was lower with zanubrutinib. You know, neutropenia is something that we kind of linked with zanubrutinib, and this study, the rate was similar between zanubrutinib and ibrutinib arm. The rate of hypertension, however, was not different between the two arms, and it's fair to, when we talked about efficacy, we brought up Elevate RR. I think it's fair to say that in Elevate RR, the rate of hypertension was actually lower with acalabrutinib compared to ibrutinib and not on the Alpine study. So, and that's a topic of extensive research from the different investigators and teams to kind of study that. I think that's the short version of the reasons why we thought the longer follow-up being presented so relatively quickly after the New England publication was important. Many patients now have come off the ibrutinib arm, and the longer efficacy follow-up is not going to be feasible. So that's why we call this the final efficacy analysis. And I don't think there will be additional efficacy data from the Alpine study. Happy to talk about the current landscape, but I want to pause here to see if there's any questions before I move on.
Thank you very much, Mazyar. This is really a wonderful summary. So I think both of you discussed and mentioned, and this is really good news. It means that's the right drug when it comes to cardiovascular events where zanubrutinib is safer. We have a question from the audience about fungal infections. And let's handle the infectious complications in general. How do the different BTK inhibitors compare, and what are the recommendations there? Maybe Mohamed, you can take this, and of course, Mazyar, if you'd like to jump in.
Yeah, so certainly by virtue of the inhibiting the B cell arm of the immune system, or that afferent arm of the immune system, the incidence of infections is certainly high. I think that most reported one in this study was, I believe, the pneumonia syndromes, which were described in this study. And I think that is not unique to one particular product over another. I think that the question of infections is, or fungal infection particularly, the difficult part there is really the drug-drug interaction. And probably I will certainly be curious to see what Mazyar thinks about that, because really these drugs are very sensitive to interaction with CYP3A inhibitors. So anything that has to do with azoles, particularly itrafluconazole or voriconazole, would be concerning for this particular product. So I would say that infections are not surprising to happen here. And I think that, as I mentioned, I think that the incidence of pneumonias was close to 20%, if I remember that correctly. Upper respiratory tract infections, I mean, was 29% versus 35%. So not unique for ibrutinib. In terms of fungal infections, I would say that it's probably in the relapsed refractory setting, you have to take into account also the prolonged treatment of these patients. I mean, these patients have been on several lines of therapy. I think for this particular Alpine was only one median line of therapy, but the range was up to 9 or 10 lines of therapy for patients. So I would say that, yes, it's not surprising with the depth of B cell suppression to see infection, and with prior therapies that probably include purine analogs to also, this patient could have also an aberrant T cell function as well. I'm happy to hear what Mazyar has to say about that.
Mazyar?
Yeah, not much to add. I 100% agree. I think this this study is specific. First of all, to comment on Alpine and then more of a general comment. I mean, if you look at the rate of opportunistic infections, I'm looking at the publication, the presentation publication has like maybe a couple of months longer follow-up. We're like less than 2% for all grades, numerically 1.9 versus 1.5, which may be higher in Xanu. I don't know if that's any meaningful statistical difference. I think the key in practice, number one, I don't routinely use prophylactic treatment for the reasons was mentioned. I mean, drug interactions are a major limiting factor. Even without that, I think, in general, the rate is very low now that our patients are less chemo exposed, and we use these agents in the first and second line. So we don't see that. One area that I'm very, I think we should be all thinking a little bit more about is concurrent use of corticosteroids, where early on with ibrutinib, of course, the data with CNS lymphoma and the TEDR regimen and, the whole story about fungal infections. But we do see in practice, even with, and I won't name any drugs, but any BTK inhibitor, regardless of the generation, when patients go on corticosteroids for other reasons, we got to be thinking about fungal infections, because unfortunately, when you treat enough number of patients, these things happen, and that doesn't have to be ibrutinib. Even novel BTK inhibitors, when given with a significant duration of therapy with corticosteroids, are associated with a higher risk of infections, fungal infections that are not easy to treat. So, but beyond that, it's really a case-by-case discussion. One area that we should be thinking about that is CAR T patients who come for CAR T therapy. Commonly, these patients go on corticosteroids either before, if they're referred to us too late, and we have to use high-dose corticosteroids for disease control, and we usually keep them on BTK inhibitors, or after CAR, they may need corticosteroids for treatment of complications. So we need to be thinking about, and different institutions have different guidelines. We, for example, here in Seattle, if patient goes on corticosteroids for certain duration of therapy, even if they're not on BTK inhibitors, they receive a fungal prophylaxis or secondary prophylaxis for a while. So kind of case-by-case discussion, and important to kind of keep that in mind.
Thank you very much. Let's go now to the mechanism of action. And we have a very interesting question here from Dr. Sullivan Stutz regarding the mutation profile of these different BTK inhibitor. And I'll try to reword a little bit the question, whether definitely each BTK inhibitor may be linked to one or different mutations. So how to optimize the use of these BTK inhibitors, and whether one agent can overcome or bypass the resistance to another agent. How do we do this in practice? Who wants to jump in? Mazyar, yes, please.
I'm happy to start. So maybe to give some background to our audience. So there are some conventional known, I shouldn't call it conventional, some known resistance mutations that we learned from ibrutinib, right?
Classical. Let's call them classical.
Yeah, C4081S, the gain of function PLC gamma 2, and then when we got pirtobrutinib approved, we learned about some other mutations that were associated with pirtobrutinib progression, mutations like L528W or M474I. And then when we got the zanubrutinib and acalabrutinib, we started seeing very small case series. For example, the group from Australia published on, I believe, 13 patients, and a significant number, more than half, had this L528 mutation, which is the kinase deficient or kinase dead mutation. And then there were like kind of reports from acalabrutinib progressions that you do see that M474I mutation, which is kind of the gatekeeper mutation, they call it. And the question was, okay, these drugs are now sharing resistance mutations with pirtobrutinib. If you're using pirtobrutinib down the road, is there a problem? Because once patient progress on either acala or Xanu, then maybe pirtobrutinib doesn't work. So I think in general, we got to be very careful using small numbers and case series in making clinical decisions about sequencing for the following reasons. Number one, the best data is from the Bruin trial, from the pirtobrutinib trial, and every year they're showing who comes to pirtobrutinib therapy with what mutations and what happens. And we're seeing the percentage of patients coming with either 528 or 744 mutation, 474 mutation going up and down. So I don't know if you can tell which mutation is more common. Number two, the Bruin is reporting that pirtobrutinib works in everyone regardless. That's a little bit of a questionable statement because works by overall response, I don't think it's meaningful in CLL, and they're not yet reporting the PFS, which, it's fair to believe that it's going to be different. Then it's important to know what's the VAF, what's the frequency of the mutation. You're looking at 5% versus 50%. There's a big difference. And more importantly, I would say there are two publications recently, one from the Elevate RR group, the other one from the Alpine group. Elevate RR, I believe, was published in, I want to say Blood or Blood Advances, and the Alpine we just published a couple of weeks ago, actually, in Blood Advances. And what we're showing that the most common mutation that patients after progression are showing actually are not the 474 and 528. Yes, they're there, but that's not the main explanation. So I think to make sequencing decisions, I wouldn't look at the case series or case reports. You got to look at the clinical outcomes of studies like Alpine and Elevate RR. An example would be if you treat 1 million patients and 3 progress and 2 out of 3 have a mutation, could you say that you shouldn't be using that drug because those 2 patients will not respond to pirtobrutinib? It's really how many patients need a subsequent therapy and how many patients with that mutation may not respond. And I would add, this story, if you want to go by looking at mutations, is actually more complicated. There's now a case report of BTK degrader progression associated with some kind of a mutation. And there's a nice paper just came out of Blood, again, a couple of weeks ago by Contam and group, and it's nicely summarizing all this. I think this is an active area of work and important academic research. I would not personally use it except for if I have someone coming off a covalent BTK inhibitor and I'm deciding on next treatment, I would definitely check for mutations. If they have a high VAF of 528 or 474, do I trust pirtobrutinib? Probably not. I would put them on them and work on CAR-T or other clinical trial. But I would not use this information to make sequencing decision of using any of the BTK inhibitors as first line or not using them. Sorry, long answer.
Yeah. No, I if I may say also, I totally agree with with Mazyar that in a way we have to look at the scope of percentage of these events happening. So yes, if you see a few percentages of 528, but as he said, basically, it's not something where you would really judge the drug to be not the best one to put in the front line. So I think that it's important to emphasize that when these patients are treated with BTK inhibitors and you see a lack of response or progression, to evaluate for mutations. And that mutational panel will help you kind of decide for the next likely drug. And probably if 528 is confirmed, the L528, probably enrollment in a clinical trial would certainly be the best approach to proceed and pursuing that particular case. Ultimately, the patient will need to go to a more definitive therapy, whether that's going to be CAR-T or still, I think transplant is not out of the list of options for those type of patients.
If I may add one last thing, there are 2 prospective studies that are looking at this question at a much cleaner kind of, with a much cleaner design. There's a study called BOSS trial that is taking patients who received acalabrutinib as their first-line therapy, and when they have progressive disease, they go on pirtobrutinib, and they have the option of going back on acalabrutinib. So they look at the resistance mutations. So we will learn a lot from this study, and a similar design of study is being done in Australia, from what I heard, looking at the same kind of a question with zanubrutinib. So hopefully we'll have cleaner data in the first line with no confounding from prior treatments. So we'll learn more about this.
Wonderful. Thank you very much. Let's tackle the last topic of this journal club because it's fascinating. We can discuss for hours and hours. And this is about overall survival, but also MRD. We have a few questions about this. I think majority of us are believers in the value of MRD, but also as a surrogate marker, maybe for the overall outcome and survival. And I must confess, last week, I personally was very surprised I know it has nothing to do with this trial, but maybe we can get your thoughts about this issue. The Amplify trial published in the New England Journal of Medicine, where the depth of MRD was not necessarily correlated with overall survival. And I wonder, what's your take on this issue of MRD in CLL? What's its value? Should it be a target for treatment? Should it be used to modulate the treatment, to have like a fixed duration, stop the treatment, guide the treatment? What can you tell our audience about this? Mohamed.
Well, if I were to basically say, I think that the field is learning about how to try to incorporate this information. I mean, historically, MRD was limited to clinical trials, was kind of an outcome, more of like a scientific curiosity, in my opinion. I think where the value of MRD appears to have some role, in my opinion, is when you really try to implement time-limited therapies, right? I mean, you are trying to guide yourself, and this is pretty much what was done by the UK group with the FLAIR study, where they look at MRD, and if the patients attain MRD, let's say after 1 year, an MRD negative status, then they will continue that treatment for another year. And if you take 2 years, then they will continue for 2 years. So I think it's probably a marker if you were to implement it in a time-limited therapy, provided that the patient does have a complete remission from the lymph node response. So I'm kind of aware of because I read also that paper with some interest, and it's interesting because if I remember correctly, the Amplify, again, we're trying to go a little bit of the topic here, but the 3 arms were pretty much chemoimmunotherapy or acalabrutinib plus venetoclax or acalabrutinib venetoclax or obinutuzumab. So interestingly, the regimens that contain monoclonal antibodies, whether FCR/BR or the AVO, did have a higher rate of MRD compared to the acalabrutinib venetoclax, even though survival or PFS and OS did not really were seen there. So I think that the jury probably is still out in terms of MRD, but I would say that in certain situations seems to carry more weight. I would say, again, diverting a little bit from the topic, if you were to look at those patients who have MRD positive disease post-CAR T-cell therapy with residual disease, those patients don't do well, and they're going to be the ones who are going to lose the response quickly. So MRD, we are still learning how to do it. And the second question is, what is the cutoff for MRD? Is it going to be the 10 to the -4, the 10 to the -6? Obviously, the more you go deeper in terms of assessing response, you're going to probably see differences there and whether MRD4 or MRD6. So I think it's a good question. I would say that I would use it if the intention is time-limited therapy with the intention of monitoring them in case you need to reinstate therapy subsequently. But apart from that, I would say for these particular settings in relapse disease where you anticipate a continuous therapy until clinical progression, I don't really clearly understand the value of MRD. So that's my opinion, but I'm curious to see what Mazyar has to say.
Yeah, no, great points. I think a few maybe to add. Number one, I think in CLL, not all MRDs are created the same. It does matter what treatment gives you that UMRD. It's different. We're learning it's different if you get an MRD negative response from chemoimmunotherapy versus venetoclax or obinutuzumab versus BTKI plus BCL2 inhibitor. So when we look at clinical trials comparing different types of therapy that I just mentioned, it's very hard to use MRD as a surrogate because the behavior of disease progression after that, even MRD negativity, is different, whether or not you achieved it with chemo, with ven, obino, or with BTKI plus BCL2 inhibitor. In case of BTKI, BCL2 inhibitor, IGHV mutational status clearly is an effect modifier. So it does matter how you get MRD and you're mutated or unmutated IGHV. The rate may be higher with unmutated, but it comes back faster if you're mutated. So it's really difficult to judge it. So number two, so in my opinion, for clinical trials, if you're comparing two regimens that are exactly the same, let's say a Cala plus Ven versus Zanu plus Sonrotoclax, and you stratify by IGHV, by all means, I think MRD is your primary endpoint to look at. It could be a primary endpoint that you know that you're comparing similar treatments, you know that you're balanced with IGHV, and you can expect a pretty good correlation with PSS. But comparing different types of regimen, I think it makes it very difficult. To Alpine, I think the big well, I shouldn't say disappointment. I think many of us expected a better UMRD rate with like A plus V maybe, which wasn't achieved. I would be a little bit, and again, maybe this is too academic, but why not? This is a journal club. That's why we're having this discussion. So if you look at the design of Amplify, the secondary endpoints are supposed to be looked at a sequential hierarchical method, meaning that if you don't meet one secondary endpoint in that order, you can't technically look at the next one. So the hypothesis was that A plus V gives you a higher UMRD rate compared to chemotherapy, although what was seen was actually reverse. So the UMRD rate was higher with chemo versus A plus V, which is okay. We just said that we don't know what it means when you're comparing different modalities. But what it also means that then you're not moving forward to look at overall survival, because on that hierarchical method, you did not reach the predefined prior kind of hypothesis, right? So, I know we're not the statisticians, but I don't know if the study's powered for OS to be anything more than descriptive at this point. And again, the paper was very carefully written for that regard, which I really appreciated, because we have other examples of not publications not following these rules, but just with that in mind, I think waiting for longer follow-up would be important. I'm also a little bit surprised on why Amplify done at the first line setting in the current era could even give you an OS difference, with so many effective treatments of being available down the road. We know many of the OS events are, all the OS events are death, and many of them are not disease related. So maybe it's COVID and infection. So that may explain a little bit, but it's very difficult to see an OS difference in a frontline CLL study done in the past 5 years. I mean, look at Sequoia. We just published a long-term and other studies. So I think we need to see longer follow-up.
Wonderful, guys. I think this is amazing. One last question, maybe short answers. What's next, in your opinion? What do we need to do? Where is the gap? What's your future trial if you have better ideas? Mohamed?
So I think that for those patients that you are aiming for a cure, be more aggressive treatment with, I think that the future probably will consolidate efforts to implement time-limited therapies with, again, MRD-driven in terms of probably assessing those patients who could safely discontinue. What will be the gold standard for MRD? That remains to be defined, in my opinion. Intuitively, probably moving to 10 to the -6 makes more sense if you were to go after a cure and go after a discontinuation, but certainly that's easier than done. I would say that the excitement in the relapse refractory setting, there are now more therapies to incorporate. I would anticipate that probably drugs like pirtobrutinib, which has been described in a phase 2 study at ASH, where it's being moved to early lines of therapy as in combination as a triplet. So that certainly we may see a little bit of trying to shift those novel therapies to an early phase. Very exciting data on the bispecifics. I would say that that would probably compete with CAR T-cell therapy, perhaps, for that population, and also with BTK degrader. So I think that field of relapse refractory is where a lot of research will be happening to try to define better the algorithm. But in my opinion, patients who relapse with CLL, clinical trial remains the best option when you need to go to the best therapy if you have such trial available at your center.
Thank you. Mazyar, you have the last word.
There's not much to add. I think finding the best time-limited therapy in the first line, finding drugs with effective mode of action in the relapse setting. We still have patients coming to us after these two classes, finding what's the role for stem cell transplant. I know that this group at least has, we still have patients who are benefiting from it even in the current era, and optimizing this T-cell therapy, whether or not it's CAR T or T-cell engagers. I think these are active areas of research. And MRD, if I may, just for 30 seconds, I like to see MRD in design of studies to find what's the optimal duration. I don't know how practical it is to use it in practice. When I look at the UK FLAIR study, an amazing study in terms of design and implementation and positive OS advantage over FCR, but how often do we use it in practice because the complexity of doing and monitoring this MRD. So I think it's valuable probably in finding what's the best time-limited therapy, probably a little bit less practical for use unless we come up with something very user-friendly.
Wonderful. Thank you very much. Thank you all for joining today's ICH Journal Club, dedicated to the Alpine trial in CLL. A special thanks to our great panelists, Dr. Shadman, Dr. Kharfan Dabaja, for the insightful discussion and, of course, for sharing their expertise. A special thank you to the engaged audience we had today. Thank you for the thoughtful questions and contributions. I believe this session has provided a deeper understanding of this, of the impact of this trial on clinical practice, but also I think we discussed a few exciting future perspectives in CLL therapy. We look forward to seeing you at our next Journal Club, but in the meantime, I'm sure you're going to enjoy the ICH activities. So this is the ICH around the globe and across the hematology field. Take care and see you soon. Thank you.